Hi guys, welcome to our Sureshot series. Today we are going to discuss about the arterial blood gas analysis and its disorders. This is one of the most important topic of your Fmge examination. From the past 5 years, the question from the ABG analysis is repeating question. So before we start the discussion, I would like to say please do subscribe to our channel. The support and the subscription from you guys will help us to do more videos and more content creation for the examinations content and also the medical related content. So please do share with your friends and subscribe to this channel. So let's start our discussion. ABG analysis. What is this ABG analysis, guys? This is your arterial blood gas analysis. Why we are going to take from the arterial side? Why not the vein side? Because most of the analysis from your biochemistry labs, that is all from your vein puncture side, right? But why arterial blood gas? Because this will give the more reliable values. Okay, so the more reliable values will be coming from the arterial blood gas analysis. What are the sites we can take? We can take from the brachial artery, or we can also take from the radial artery site, and we can also get it from your femoral artery. Most of the emergency technicians and the emergency departments, they prefer the femoral artery. And before we do the arterial blood gas analysis, we are going to perform this test. This is also one of your previous year question only. Before I'm going to tell about the test, please do comment in the session if you already know about this test. So this is your modified Allen test. What we are going to do in this modified Allen test, please look at these images. The first thing you have to do is, when you are going to take the sample from your radial artery, please do occlude the both arteries. One is your ulnar artery and other one is your radial artery. Occlude both and check whether the complete circulation to your digits, your distal hand, is completely blocked and it is turns into the pale color. After that, release one of your hand from your ulnar side and look it for the 15 seconds. Within the 15 seconds or less than 10 seconds, the flow, the collateral flow covers all entire the palmar region and entire your distal hand, so that circulation and the ulnar artery patency and the circulation is intact. Then you can good to go for puncture the radial artery and get your sample. But if it is not completely not going to flush and not going to circulate, the collateral circulation from the ulnar side is absent, it is a contraindications to take from the radial artery. You can opt for the brachial artery or the femoral artery. So the main theme of the Allen test is check for the patency of the both radial and the ulnar artery. Okay, so both patency and flow of the ulnar and the radial arteries, guys. So whether the patient is having the any aneurysm, or the patient is having the acquired fistula, or the patient is having the congenital abnormality, this can cause the gangrene or the vascular digital ischemia. So that's why, to avoid this condition, we are having this modified Allen test. Here also you can see clearly, this is your modified Allen test. You have to occlude both arteries, the ulnar and the radial artery, and check whether the palar region is coming or not. And after that, release one of your hand from the ulnar side and look at the flush and the flow of the ulnar artery collateral circulation. And what are the indications? Why we do this ABC analysis in the first place? What are the indications? Basically, the indications of this is ICU patients. Those who are having the ICU patients on the mechanical ventilations, ARDS, pneumonia patients, we are going to perform the arterial blood gas analysis. And those who are suffering from the chronic respiratory conditions, especially your COPD patients or the obstructive patients like status asthmatics, all these patients we are going to check. And next, those who are coming from the DM and the DKA, your diabetes mellitus and its common complication, diabetes ketoacidosis, or the patient those who are coming from the lactic acidosis, or the patient is coming from your alcohol intoxication, or those who are suffering from the patients, those who are having this common conditions like poisoning, and even those who are patients coming from the intoxication, the drug intoxications, or the patient those who are having the severe shock-like symptoms, all these patients we are going to check the ABG analysis. These are the common indications where we are going to perform the ABG. And next, let's move on to how to interpret this ABG analysis. Here you can look at the graph. The normal value of our body, normal pH value of our body is the 7.4. This is the normal, and common value of all our bodies is the 7.4. And next, coming to this, The first thing that you have to remember, what are the acidic in nature and what are the basic in nature. The acidic in nature, we have the CO2 and we also have the H plus ions. And coming to the basic, that is your HCO3 ions. These are in the basic in nature. So we are commonly, the whole ABG thing is coming from this acidic in basic natures and also your pH values. So what is the acidosis and alkalosis? Remember that your pH is 7.4, right? If it is less than 7.4, that your body is in the acidic, going in the acidosis. But if the pH is more than that, then it is in the alkalosis state. So this is how we are going to check whether our body is in the acidosis in nature or the alkalosis in nature. So here we commonly have the 4 kinds of disorders, guys. One is your metabolic acidosis, and other one is your metabolic alkalosis, and other two are your respiratory acidosis and respiratory alkalosis. These are the 4 common disorders we encounter in the all ABG analysis. Before we are going to proceed this, I want you guys to know about the what are the normal values of this ABG analysis. The pH, you don't have to mug up the what is the normal values and what is the interpretation, this much to this much, don't have to remember. I will just simply tell with the mnemonic of the 4. Let's remember your 7.4, your normal pH value, and your carbon dioxide, that is your 40 mmHg. And next coming to your HCO3, that is your 24 milli equivalents per liter. So this is your mnemonic. Let's remember pH is 7.4, PaCO2 is 40, and HCO3 is your 24 milli equivalents per liter. So, but how we can see interpret this 4 kinds of disorders, guys? See, when your pH is low, this is your acidosis, right? At the same time, your metabolic content is also going to decrease. Same with the PaCO2. All the values is decreased, then it is your metabolic acidosis. And coming to the metabolic alkalosis, as I said, your primary defect, the pH is more, that is your alkalosis. And HCO3 is also going to rise, and PaCO3 is also compensation, it is also going to rise. But opposite to that, in the respiratory conditions, acidosis means your pH is low, but your respiratory conditions is opposite, as I said. So this is going to be rise. And coming to the alkalosis is going to high pH value, and both the HCO3 and PaCO3 will be down. So this is the, you have to understand the mechanism behind. During the metabolic acidosis, your HCO3 is obviously low, but why your PaCO2 is also low? Remember, as I said, the CO2 is your acidic in nature. Your already body is in the acidic in nature. Because of that, your body is going to do the hyperventilation. Your body is going to hyperventilation. So that's why your body is going to eliminate the PaCO2, and you are going to having the acidic in nature will be decreased. And next coming to the alkalosis, during that PaCO2 is going to hypoventilate, so that the more and more PaCO2 will retain in our body, and our acidic nature, the pH will be going to decrease and coming into the normal value. This is how the normal compensation of the body will be occurring. So that's why we are going to see during the metabolic acidosis, the PaCO2 value will be decreased. During the metabolic alkalosis, our PaCO2 will be increased to hypoventilate and retain more and more carbon dioxide inside, and it will make the pH normal. So this is how the compensation will be occurring. Here the summarized table, you can see the metabolic acidosis, your CO2 will be decreased. To compensate that, HCO3 is also decreased by the respiratory compensation of the hyperventilation. And HCO3 is going to reabsorb from the kidneys. Why HCO3 is HCO3 is already getting into reabsorbed by your kidneys? See, your H plus ion in your acidosis, whole body is in the acidic in nature. Your HCO3 is the basic, right? So to compensate this, you are making your body into the normal pH. You are going to reabsorb the more and more from your kidneys. Same with the alkalosis, where CO2 is already high, but your body is low acidic in nature. So that's why HCO3 is going to decrease, and HCO3 is excreted from your body, so that you are bringing your body back into the normal pH or the making it to the compensate to the acidic in nature. So this is the common disorders that we see and common how we can correct this by the normal compensation, right? I hope you have understood this table, and this table is going to most important for you guys. Understand? Next. And also in the next slide, we are going to discuss about the what are the conditions that will be having these problems and how to we can correct. And I want to know about the what are the causes, what we having this normal causes of your metabolic acidosis and metabolic alkalosis. Common conditions you see in the metabolic acidosis is your DKA, and other one is your lactic acidosis. These are the common conditions you encounter with the metabolic acidosis, and also some of the salicylate poisoning, glycol or the methanol poisoning. These are the conditions you will be encountering the metabolic acidosis in the patient. And what are the conditions? Metabolic alkalosis, those patients who are on the loop diuretics, or those patients having the severe vomitings, and those who are patients having the hyperaldosteronism. These patients will be having the metabolic alkalosis. And next common conditions we have respiratory acidosis and respiratory alkalosis. These are also patients, those who are suffering from these common disorders only. But due to the compensation of your lungs and kidneys, these patients will be having the COPD, ARDS, or the opioid poisonings, and patients those who are having the O2 toxicity, and even patients those who are suffering from the aspiration. These are the common conditions you will be seeing the respiratory acidosis. And respiratory alkalosis patients commonly in the sepsis patients or the stroke patients and emboli pneumonia patients. These are the common conditions you will be seeing these conditions. To trick this question and make it hard, they will be asking about the compensation. How you are going to interpret the compensation of this disorder. To say these three examples is belongs to one patient only, but by correction, but what are the treatment we are giving, this patient is improved and we are going to check his compensation. Let's see on the directly when we are encounter this patient on the emergency room, on the examination on the electrolyte imbalance and also the patient ABG analysis, we came to know his pH is low. That means his primary disorder is acidosis, and his both CO2 and HCO3 is also low. Then this is considered as a metabolic acidosis. As I said, when you are saying the metabolic acidosis, what are the other one is going to compensate? That is your CO2, right? You can see your CO2 is also decreased as the HCO3 is decreased. Then this is considered as a partial compensation of the metabolic acidosis. Okay, this is a partial compensation of the metabolic acidosis. And after 2 hours, this patient is having the pH is normal, your CO2 and HCO3 is still in the primary disorder only. Then means your pH is already normal, your body is trying to compensate it, is already, your compensation is completed. This is the full or the complete compensation. This is your complete or the full compensation of the metabolic acidosis. Next, after 2 hours, this patient is still worsened and this patient is having the uncompensation. Okay, your CO2 is not compensating because your CO2 is normal. What we have to see usually in the metabolic acidosis, pH is going to decrease. Here it is still normal, it is not acting. So then it is a uncompensation of the metabolic acidosis. So this is how you are going to interpret the compensatory effects of our body. And other formulas also you can use, that is your commonly known as your winter formulas. These are the compensatory mechanisms you can. Actually, your respiratory compensation is more faster than the kidney. Okay, your respiratory compensation is more faster than the kidney. In your metabolic acidosis, when the compensation of the PaCO2 is 1 milliequivalence is going to decrease in the HCO3, 1.3 mmHg of the PCO2 is going to decrease. So here the examiner is trying to say for the 1 milli equivalent, it is going to decrease the 1.3 mmHg. So 1.3 mmHg of the compensation will be done by the respiratory side. Same with the alkalosis, 1 milli equivalent of the HCO3 is going to increase at the time of the 0.7 mmHg PCO2 increase. So coming to the respiratory side, see for the respiratory acidosis, for the 1 PCO2 decrease, your HCO3 is going to compensate by the 0.1 milli equivalents of the HCO3 is going to increase. All right. And next coming to the respiratory alkalosis, for the acute 1 CO2, you are going to decrease the 0.2. Okay. So 1, 1, 1, 2. That's how you can remember. For the 1, you can see on the chronic side, both are going to increase the 0.4 only. For the chronic conditions, 0.4. So this is how can you remember 1, 2, 4, and 4. So this is the respiratory acidosis and their compensation. Please try to remember this table also. And next we are going to move on to the next topic. So in the anion gap, we are going to have the two kinds of anion gap. Before that, we are going to discuss what is the normal value of the anion gap. That is your 8 to 12 milli equivalents per liter. And how to calculate this anion gap in our body? The formula for the anion gap calculation is sodium minus chloride plus HCO3. Okay, sodium minus chloride plus HCO3. This is the formula for the calculation of the anion gap. And next, we are going to check there are two kinds of anion gaps. One is your hagma and another one is your nagma. All right. What is a hagma and what is a nagma? Hagma is your high anion gap with the metabolic acidosis. And the next one is your normal anion gap with the metabolic acidosis. What are the conditions that commonly we see? The common conditions of the hagma is your salicylate poisoning. And other one is your DKA. And also your lactic acidosis condition or the glycol poisoning. And those who are having the methanol poisoning. And those who are suffering from the renal failure. These are the conditions that we see in the hagma patients. And next coming to the nagma patients, that is your osmotic diarrhea. Okay, that is your osmotic diarrhea patients or the common condition like renal tubular acidosis or patients those who are suffering from the Addison's disease, aldosterone disorders like Addison's disease, and those who are suffering from the sudden saline infusion. So these are the conditions we see the high anion gap. Okay, so anion gap, at least you have to know the names of this, like what is the high anion gap with the metabolic acidosis and the normal anion gap metabolic acidosis. All right, next, this is a summarizing table here. Please do understand that when you are having the normal pH value, that is your 7.4, but your pH value is less than 7.4, then this is your acidemia. If it is more PCO2, then respiratory conditions. If it is a less PCO2, that is your metabolic acidosis. And you have to check the anion gap of the patients. If it is more, the high anion gap, here you can see the glycol poisoning or the patient is having the lactic acidosis, methanol poisoning, salicylate poisoning, and renal failure, diabetic ketoacidosis patient. Next, coming to the normal anion gap, then the patient is likely to having in the Addison's disease, renal tubular acidosis, diarrhea, or the saline infusion. So these are the conditions. But when you say the 7.4 is more, then the patient is going into the alkalemia. If it is the HCO3 is still more, then it is your alkalosis. And check for the conditions what are this patient is having. Is the patient is having the vomitings, loop diuretics, or the antacids, or the patient is having the respiratory conditions, anxiety, hypoxemia, tumors, or the pulmonary embolism. So this is the summarizing and the most important topic. Try to understand better and how to interpret immediately in the examination and also immediately in the emergency situations. So thanks for joining this session. Please do subscribe and share it with your friends.